I'm Micha Vidot, a two-year medical student from St George's University of London, and this session will be covering pulmonary emboli. Before we officially begin exploring PEs, I would just like to mention it's important to have a list of differentials for a patient presenting with chest pain or dyspnea. Having a skeleton list in your mind can help you during your clinical decision-making in both the knowledge and clinical exams. Here's an example of a differential list that I've made. Now on to a PE. In terms of signs and symptoms of a PE, the patient may present with pleuritic chest pain, dyspnea, hemoptysis, tachycardia, tachypnea, hypertension, and cyanosis. On occasion, patients can also present with crackles in their lungs and a fever. It's important to note that only 10% of patients will actually present with the textbook triad of pleuritic chest pain, dyspnea, and hemoptysis when they have a PE. Moving on to investigations. I like to split my investigations up into background, which is taking your patient history, bedside, bloods, imaging, and invasive investigations. In terms of background, it's important for you to identify any patient risk factors for a PE. These being recent surgery, a long-haul flight, pregnancy, thrombophilia, a recent leg fracture, as we're thinking of fat emboli, malignancy, the combined oral contraceptive pill, hormone replacement therapy, or a previous PE. Moving on to bedside tests. An ECG is the only bedside test which we can use to help identify a PE. Typically, it may show sinus tachycardia. However, an ECG may show large S waves in lead 1, large Q waves in lead 3, and an inverted T wave in lead 3. This can easily be remembered as S1, Q3, T3. Additionally, a right bundle branch block and right axis deviation may be seen. Before we go any further in terms of investigations, we need to determine the patient's well criteria score, as this will determine which investigations we do next. As you can see, different features have a different score, which you would add up, and if the score is greater than 4, your patient is deemed likely to have a PE. If a PE is likely, you can perform an ABG, which would likely show hypoxia, but can also indicate if the patient is in acidosis. It is recommended to do an immediate CTPA if a patient has a well score of greater than 4. This involves the injection of contrast media into the patient. Therefore, if the patient is allergic to contrast or has renal impairment, you can instead perform a VQ scan. If there will be a delay in the patient having a CTPA, it is recommended to give low molecular weight heparin in the meantime. On the screen now you can see an example of a CTPA. Here is the chest, the back, the right side of the body, and the left side of the body, and this white area in the middle is the pulmonary vasculature. On this new image, we can see that along the pulmonary vasculature there is a filling defect in the right pulmonary artery. This would indicate a clot in the lung. Tests which are not necessary but can be done are routine bloods, in case there is a blood-based abnormality which has caused a PE, a chest X-ray, which may show decreased vascular markings or wedge-shaped areas of infarct, and a Ddimer. The issue with a Ddimer is it has low specificity, meaning that it can be raised when there's a thrombus, when there's inflammation, if your patient is post-op, if there's an infection, if there's a malignancy, and if your patient is pregnant. If your Wells criteria score is less than or equal to 4, a PE is deemed unlikely. You should start by doing a Ddimer, and if this comes back positive, the patient should be sent for an immediate CTPA. You can then perform an ABG, chest X-ray, ECG, and lower limb ultrasound in order to investigate for a different cause for the patient's symptoms. The management of a PE is divided depending on if the patient is hemodynamically stable or unstable. Starting with a hemodynamically stable patient, as soon as a PE is confirmed, low molecular weight heparin should be started and continued for at least 5 days, or until the patient's INR is greater than or equal to 2 for at least 24 hours. A vitamin K antagonist such as warfarin should be started within 24 hours of the patient's diagnosis and continued for at least 3 months. At the 3-month mark, the patient's physician should reassess the risks and benefits of continuing treatment. If the PE was unprovoked, NICE recommends to continue anticoagulation therapy for longer than 3 months. Alternatively to warfarin, a direct oral anticoagulant such as rivaroxaban or apixaban can be prescribed. If the patient is contraindicated to anticoagulation, you can consider a vena cava filter. If your patient is hemodynamically unstable, you begin by providing oxygen at 10 to 15 litres per minute if they are hypoxic. 5 to 10 milligrams of morphine and antiemetics can be provided if your patient is in pain. The patient should be started on low molecular weight heparin, and if they are hypertensive, given a 500 ml IV fluid bolus, and you should get ICU input. If the patient is still hemodynamically unstable, begin thrombolysis using alteplase, and then initiate the long-term anticoagulation pathway, which is what we spoke about for our hemodynamically stable patient. If the patient had become hemodynamically stable, but they still had a low blood pressure, you could give vasopressors such as dobutamine or noradrenaline, and then initiate the long-term anticoagulation pathway. If the patient is having repeat pulmonary emboli when they are on anticoagulation therapy, you should consider implanting an inferior vena cava filter. This is supported by NICE, however, be aware that there is a weak evidence base for the filter. As pregnancy is a risk factor for PEs, it's important to know the rough outline of the management. Initially, it's important to involve all senior physicians, obstetricians and radiologists in the patient's care. The patient should be started on low molecular weight heparin and continued on it for the remainder of the pregnancy and at least 6 weeks postnatal. The goal is to have at least 3 months of using low molecular weight heparin. Then at the 3-month mark, reassess the patient. Please remember, you cannot give a vitamin K antagonist such as warfarin to someone who is pregnant, as they are known to cause fetal defects. In terms of complications of PEs, they are a major cause of mortality, morbidity and hospitalisation in the UK. The mortality rate is lower if the patient presents hemodynamically stable and significantly higher if they present in cardiorespiratory arrest. If a PE is severe enough, it can also cause sudden death. A massive PE, which is a PE where the systolic pressure goes below 90 or has decreased by 40 for at least 15 minutes, has a mortality rate of 18 to 65%, but this is lower to 20% after treatment. Out of 100,000 pregnancies, 1.39 mothers die during the pregnancy or up to 6 weeks after the birth due to a PE. A rare complication of a PE is chronic thromboembolic pulmonary hypertension. This is when the emboli is replaced by fibrous tissue, leading to the obstruction of pulmonary arterial vasculature, a progressive increase in pulmonary arterial pressure, and then right-sided heart failure. The risk of this complication is increased if the patient receives inadequate anticoagulation, if they have a large thrombus mass, any residual thrombi, or a recurrence of the PE. A PE can be prevented by providing heparin and TED stockings to immobile patients, stopping hormone replacement therapy, or the combined oral contraceptive pill. It is also recommended to walk around on long-haul flights to prevent the development of a DVT. On the screen, I have listed the resources I have used to prepare this session. I hope you have found this useful.